My title is My Bladder is Broken, and you may have felt that way before, that things somehow just aren't working like they used to and definitely not like they should, but you're not exactly sure why or how it got to be that way. So this is our basic bladder anatomy. It's really just a bag of muscle. That's really what the bladder is. It's a bag, it empties, it fills like any other bag, but it's made up of muscle. And if you were able to digest the lining of the bladder, either on the outside or the inside, it would actually look kind of like a ball of yarn. The muscle goes every single which way so that when the muscle fibers contract, they contract concentrically and evenly. Unlike your arm, which maybe all the muscle fibers go in one direction, so it provides that sort of movement. The bladder has to squeeze three-dimensionally, so it's a bag of muscle. It's able to stretch as it fills, thank goodness. It's filled by the kidneys, which sit right up here, make the urine, they come down these ureters, and then fill up the bag. The exit is at the bottom, which is a design flaw I'll bring up later on to somebody else. But the exit is at the bottom, and it's protected by a sphincter muscle down here in the ladies, and right here, it's very similar place in the men, that prevent this from draining when it shouldn't. Now, the bladder really just doesn't do anything else but hold our urine until it's socially appropriate not to hold it anymore. If there was no such thing as social appropriateness, we probably wouldn't even need a bladder. It could just come out all the time like birds or other animals. But for some reason, our species decided, we really don't want to let this go any old time. So let's come up with this bag that we can carry it around until it's okay to let it go. And that's how the bladder works. The important differences between men and women are, one, this little gland right here called the prostate that men have. It really only serves one real function, and that is to make semen. Other than that, it's pretty much worthless, other than to cause problems. So that's that we have in the men, and that kind of leads to complicating the overactive bladder picture in the men. The other difference is the length of the urethra. You can see that here in the ladies we have a short urethra, and it actually does not go much beyond this muscle band in our pelvis, whereas the men's urethra goes quite a bit beyond that pelvic floor. And that introduces some more complexities for men when it comes to potential sources of overactive bladder. Like we said, the bladder is a storage bag. It doesn't make urine, it just stores it, and it stretches. So as it fills, and this wall of muscle stretches and stretches and stretches, there are little sensory receptors here that send signals to the spinal cord that, hey, I'm feeling something. Things are starting to stretch, and those stretch receptors get more active and more insistent the more full the bladder gets. Ideally, that sensation is sent to the brain, okay? That's how it's supposed to work. The brain gets the signal that my bladder is getting full, and the first place in the brain that recognizes this is an area in the central brain called the central micturition center, in the area called the pons. You don't need to remember any of that. I won't have a test. And then that signal goes up to the brain, and that's where you consciously recognize something's going on. When you're in the produce aisle in Super One, your brain says, no, you can't do anything about that. When you're standing or sitting over a toilet, however, your brain may say, okay, you can do something about this. And you send a signal back down to this area, and the signal then comes all the way down through these motor nerves. A couple things happen. Number one, you tell your sphincter to relax. When your sphincter relaxes, a reflex then happens that allows this muscle to squeeze. Until that happens, this muscle stays relaxed in the normal situation, okay? So it stretches and stretches and stretches, and no matter how much you hurt, that muscle stays relaxed. It does not squeeze until the signal comes from the brain to go ahead and relax. And that signal in a normal situation is coupled with your conscious decision to void, okay? You consciously send a signal to your urethra to relax, and only then does this muscle generate a contraction. With this muscle open and this muscle squeezing, your bladder then empties. In infancy, it's completely different. As you all know from changing diapers and taking care of kids, there is no conscious decision to void. It just comes out, right? Because literally what's happening as these stretch receptors are sending a signal to the spinal cord, there isn't a mature system here. There is, however, an immediate reflex. The reflex is go ahead and pee. So I'm full, spinal cord, and then sometimes this pons just says, okay, go ahead and pee, and that just squeezes, and out it comes. It isn't until we mature through childhood and we learn to potty train that we impose control on this whole system from up here. Okay, this has to be learned. In the absence of this, the body already has a built-in hardwire mechanism to make sure that bladder gets empty without you. Okay? That's the infantile voiding pattern. Okay, so symptoms you all might have. Urgency. When you got to go, you cannot wait. You have to go right now. Frequency. You're going every hour or every 2 hours, or you're going 5 times a night, or even if you go to the grocery store only for 2 things, you still know where the restroom is. That's understandable if it's Costco and it's 55 things, but for 2 things, the super one, you shouldn't have to know where the bathroom is. Slow urine stream. It goes, boy, you had to go so bad, and yet, wow, it's not coming out that fast, or there's just not that much. Why did I have to go so bad when that's all that came out, apparently? Leaking before you get to the bathroom. We talked about waking up at night. Sometimes stopping and starting. This is more common in the men, but it can happen in women too. You go, and a little bit comes out, and then it stops. And then a little more comes out, and then it stops. It's like it's teasing you, right? It's not going to all just come out at once. It wants to delay it a little bit, have a little bit longer time in the sun there. Leaking when you cough or laugh. We won't address this a ton today. This is stress incontinence, but we will talk a little bit about it. Not getting all the urine out when you go, knowing that you're leaving some behind. And then sometimes having some bowel leakage as well. Fecal incontinence we'll address just a little bit today. And not everyone has all the problems. So some people can have the same underlying reason for their problem, but they may not be exactly like their neighbor. I have this and I don't have that, whereas you do. And there can be different reasons why people don't have all of the symptoms. Believe it or not, these symptoms are really interesting to people like me and my office, and we want to know all the details about them. So a lot of times when you come in to see us, if you're a man, you will almost always get this questionnaire to fill out because we actually want you to rate it for us. These are validated questionnaires, and we've learned to kind of trust the numbers that come out of this. And we actually see significant changes in these questionnaires after we treat patients. This is the overactive bladder questionnaire, and we will give that to both men and women. And you can see if you're a man, so you write down this question right down the bottom. We take care of the fact that males have problems. Are you a male? Then you get to add 2 points to your problem score, just because we realize that you're more problematic. Okay, why is this happening to me? Well, really the problem could be anywhere, and we're actually going to look at this picture a couple more times in the lecture. The problem could be down here in the urethra. It could be obstruction. It could be blocked for some reason. In the men, that might be the prostate. You could be having inappropriate signals coming from the bladder to the spinal cord or from the spinal cord to the bladder. You might have inability of this to relax right here or inability to relax your sphincter. Or perhaps your sphincter doesn't work at all and is incompetent. Perhaps you've had a spinal cord injury. Perhaps you have recurrent infections. Perhaps your bladder over time has become thickened for a variety of reasons and it no longer stretches like it used to. So figuring out where your particular problem is crucial in deciding what the problem is and what the appropriate treatment would be. Obstruction is a common one. So obstruction, if we go back to this picture, is down here. We're talking about between the bladder neck and the outside of your body. If this is blocked so the bladder can't empty effectively, obviously that's going to cause long-term problems. In men, it might be an enlarged prostate. Okay, this is where prostates cause our problems. They block things. It could also be a urethral stricture. And this is actually what we call a retrograde urethrogram, where we've shot contrast back through a urethra and taken x-rays. And you can see this is how wide that urethra should be, and you can see there's been a scar here, a stricture. So when this gentleman tries to void, it comes through his prostate just fine, but here in the urethra it meets a very tight narrowing, and that's causing problems. Happily, women get strictures much, much less than men, and part of that is because their urethra does not go beyond their pelvic floor. Here's BPH. I won't spend too much time on those for those of you who don't have one of these. But for those of you who do, this is what it can start to look like over time. This is what it looks like when men are young. And as they get older, they can develop lots of benign growth that takes this open channel to a very tight channel and causes problems. The reason that causes overactive bladder is this muscle bag is going to respond to the blockage by squeezing harder. It's programmed to respond just like any muscle. Well, if a little bit of effort doesn't work, I'll put more effort. Your brain doesn't control this. The bladder just squeezes harder in order to do its job. Year in, year out, day in, day out of this, however, this causes the bladder wall to thicken. It causes it to be less elastic, and it can prompt overactive bladder symptoms. The bladder sending signals earlier than it used to that it has to go, even when it's not as full as it used to. Also, it can lead to under-emptying, the bladder not emptying all the way, and that can cause you to go frequently. If you only get half of it out, you're going to have to go twice as often, right? And that is a common problem in men. So in men, when there's an enlarged prostate and they're not getting empty, or their bladder is working extra hard to empty, they develop secondary overactive bladder. This is not what most women get, and not what a lot of men get. This is secondary. That means the overactive bladder wasn't the first problem. The overactive bladder is only a problem because this has been there, and it's been there long enough for overactive bladder to develop. But they have the same problem: urgency, frequency, small volume voids, waking up a bunch at night, rushing to the bathroom only to find that it's pretty underwhelming when they get there. If you have obstruction and overactive bladder, you need to treat the obstruction first. This is true with women too. If a woman has a urethral stricture, and that's why she has overactive bladder, you got to treat the stricture before you can expect any resolution for the bladder. For men, this often means taking care of your prostate. Treatments for BPH start with medications, and a lot of you may recognize this little word right up here, Flomax. But medications are where we typically start for prostate treatment. After that, there are minimally invasive procedures. Urolift is one of those we'll talk about today. And then more definitive procedures such as the old-fashioned TURP or Roto-Rooter, where we actually use a loop to remove that extra tissue and leave a nice open channel, or the more modern green light laser therapies. So this is an example of someone's voiding pattern who is obstructed. And this actually could be a man with a prostate or a woman with a urethral stricture. But this curve right here is what a normal voiding flow would look like. You start urinating, it gets fast pretty quick. You're up here around 20 milliliters per second of fluid coming out. You're done and you finish. When you're obstructed, the rise goes a lot slower. This person isn't getting above 7 milliliters per second at a peak, and then there's this kind of slow, unsatisfying, spiky end into nothing with a lot of dribbling. That's kind of a common sight. All right, treatment with medications includes things like alpha blockers, Flomax and whatnot. These work pretty quick. And 5-alpha reductase inhibitors, there's only 2 of them on the market. They work a lot slower, but they actually do shrink the prostate. These 2 medications together are called dual therapy. This is the least effective treatment for prostates, BPH, okay? It's the start. It's only the start. Sometimes side effects are problematic, so we can't use it. But if it's not effective, the trouble we have with medications is men think it's working. They're like, oh yeah, I'm peeing a little better. It's not fantastic, but it's better. I'm not 25 again, but it's better. But if it's not good enough, it can lead to bladder risk for decompensation over time. Meaning the bladder, if it's still squeezing too hard, working too hard, even on medications, over time you can still develop bladder failure, worsening overactive bladder symptoms, or a bladder that won't squeeze anymore. So this is an example of an individual who first came in, he's not on medications yet. I'm sorry, I didn't get a very good picture. Not on medications yet, and you can see the bottom here is how fast the urine's coming out. This is how hard the bladder is working to get the urine to come out. I want them in the green zone. That means I have a fast flow, but the bladder's not working too hard. This gentleman's over here, his flow is really slow. I guarantee you, you're not happy at that flow, but his bladder is working really hard to get that weak flow. So if I put this man on medications, and I don't have a follow-up, but if I put him on medications and I checked him and he was down here, I'd be really happy. Sometimes what happens though is they go to here. Their flow getting better. Instead of 3 milliliters per second, they're like 7 or 8. They think that's a fire hose after peeing as slow as they did for the last 3 or 4 years. But the bladder's still working hard. And 5 years later, that can be a real problem. So it's important when we check men who are on medications to check yearly, do tests like this, and make sure they're actually not slowly damaging their bladder over time. Minimally invasive treatments for the prostate there's a bunch of them. There's the Urolift, which we'll talk about today. There's steam treatment called Resume, which I used to do and I don't do anymore for esoteric reasons that we won't go into. There's the I-10, which is a urethral cage, which is very interesting. It's kind of new on the market. And then there's a whole bunch of thermoablation ideas where you basically heat the prostate up like it's chicken and then let the body come in and absorb all the dead tissue. There's pros and cons to it, but the essential purpose of doing a minimally invasive treatment is to try not to get the side effects of a more aggressive treatment, okay? That's why they came up with minimally invasive treatments. So let's talk about the one I favor. And I'll be honest with you, I favor this one. This is the one I do almost exclusively as a minimally invasive treatment. I have used other ones before. I like this one. I feel like it has the most immediate positive outcome for men. It has the fewest long-term side effects, and it's the easiest to go in and do further treatments if you need to. It's usually done with light sedation. You don't actually remove any tissue. We come up through the middle of the prostate, squeeze it open, and use these anchoring devices to hold the channel open. This is what it looks like beforehand as an example, and then at the end, this is what the bladder opening will look like. So you can see this obstructing tissue is gone. That's the lumen of the bladder right there. So there's nothing in the way. Minimal impact on sexual function. Sexual side effects are a big deal when it comes to prostate intervention, and most of the old-fashioned Roto-Rooter treatments and TURPs caused sexual side effects, which makes men a little nervous about it. This has minimal to no impact on ejaculatory function. And the biggest reason for that is I'm not doing anything to the muscle of that bladder neck, not touching it at all, and that's crucial for preserving normal ejaculation. So most men go home same day without a catheter. Maybe 1 in 10 will have a catheter for a couple of days, but most don't. It's not really appropriate for the gargantuan prostate. So I do measure your prostate size before I could tell you you're a candidate for this. But if the prostate's not one of the real behemoth ones, it's generally a good option. Certain shapes don't work as well. Certainly we evaluate you to be sure whether that's a factor or not. So what's the success rate? About 5 years after these procedures, 13% of men will have gone on to another procedure. Okay, so 80+% of men are still happy 5 years down the road with what they chose. This is kind of just a schematic showing what we actually do. There's the scope going in, and we fire this little device over. It's totally adjustable. So this little piece is not actually put on until I squeeze that prostate down to where I want it, and then I put the final anchor on, and it holds it open. So it's very customizable, whether your prostate's 50 grams or 80 grams. I can put in 2 of them, or I can put in 8 of them, depending on what you need. So you can see that holds it open. This is kind of what the handpiece device, I don't know if you really care to see what my tools look like, but I got to fill up the space with pictures, so that's what you get right there. We're just really happy. We recently were given the UroLift Center of Excellence designation by the company based on our volume and our outcomes, so we were really happy to be able to do that. All right, so what if your prostate is too big, or you say, I don't care about minimally invasive procedure, I want the 100,000 mile guarantee procedure. This is probably where we're going to go next, green light laser ablation. How many of you are familiar with the old TURPs that we used to do, the roto-rooter procedure? Some of you know about those. We would literally cut tissue out with a hot knife, basically. And they worked fine. Quite a bit of bleeding, and men would stay overnight a couple of nights, and they were successful. This is nice because there's a lot less bleeding. I actually don't cut anything out. I'm vaporizing it with the laser. So this tissue turns into carbon dioxide bubbles, water, and a little bit of fluff, and that's it. Patients go home the same day. They have a catheter, which generally comes out the very next day. Ejaculatory dysfunction is more of an issue, and most of that is because this opening actually gets to be a little too big. And so semen flow gets disrupted. As a result, it goes backward instead of out the direction it's supposed to go. So ejaculatory dysfunction in about 75% of men traditionally. There is a new hood-sparing technique that we're using that drops ejaculatory dysfunction to about 20%, but it's still an issue. So for our younger men, our men who are still very sexually active, this is nerve-wracking for them, and so we will now use a hood-sparing technique. Retreatment rates are a lot lower. 10 years out instead of 5 years out, 1 in 10 men may have pursued retreatment. And what invariably happens is some of this side tissue that remains, you might get a little bleb of tissue that regrows, and we just have to go in and take care of it. The retreatment issues are usually much smaller deals than the original treatment. Okay, so we're done with the prostate. OAB after BPH. For most men, after we treat their prostates, the overactive bladder symptoms go away. And that's because for a lot of them, they are secondary. And once we've taken care of the outlet obstruction, the bladder no longer has to work very hard, it's emptying effectively, those urgency frequency problems will often resolve. But not all, okay? So in some men, even though the flow is better, they're emptying effectively, they still have these overactive bladder symptoms, urgency, frequency, even urgent continence. And that's because overactive bladder can be an independent problem all on its own. Just ask everyone here without a prostate. You don't have to have a prostate to have bladder problems. And so you can have bladder problems that don't have anything to do with your prostate. It just so happens that you have both. So it's common to blame the prostate for everything. So let's talk about primary overactive bladder, because we're now men and women, same problem. We're now assuming the prostate's not an issue or it's taken care of. There's no obstruction. We're just dealing with a bladder issue. Overactive bladder, 1 in 6 adults, estimated over 30 million patients in the United States have overactive bladder symptoms on some level. We've already talked about these symptoms that you might get. There are some confounders. So patients who get recurrent UTIs, anyone who's had a bladder infection knows urgency, frequency, but usually burning and other things go along with that. But certainly we want to rule out infection as a possibility for these symptoms. So overactive bladder is what's going on when there isn't an infection. Now you can have both, unfortunately. You can have overactive bladder and infections. But that's a confounder. Other inflammatory conditions like interstitial cystitis, which we won't talk about today, that's its own 2-hour lecture alone, but that can also be a confounder. Some things can make your overactive bladder worse. What you eat, stress, even just emotional, psychological stress can make your overactive bladder worse. Sometimes weight. Excessive weight can cause a problem. Interestingly, sometimes quick weight loss can be an issue. Bowel conditions can cause it. The bowel and the bladder share a nerve, and we will talk about that in a minute. But lots of constipation or other bowel issues can make overactive bladder symptoms worse. Gynecologic conditions, cancers, medications, all of these can lead on some level to these symptoms as well. So when we evaluate a patient with this, we're always looking for confounders. How can we make things better by addressing peripheral issues that are making things worse? Neurogenic bladder. Overactive bladder is really just one kind of neurogenic bladder. Overactive bladder, at its heart, is a communication problem. It's a problem between how the bladder and the spinal cord and the brain are communicating with each other, okay? It's not an isolated bladder problem. It's just that that's where you notice the problem. But the problem is this whole system. There are other kinds of neurogenic bladder because the neurogenic bladder is really a condition where the nerves that control the bladder don't work properly. So you can have a hypotonic bladder. That's the other side of the spectrum where your bladder doesn't squeeze well at all and it won't empty. You go pee, you're not obstructed, and it just doesn't come out because the bladder is hypotonic. The muscle is not squeezing like it should. And actually you can get mixed neurogenic bladder. And generally this looks like I gotta go so bad, I rush in, I can barely get on the toilet before it starts coming out, and yet it doesn't empty all the way. What's going on with that? You had to go so bad, and then you just decided to stop? Well, that's mixed neurogenic bladder, and is more common than you might realize. So things like acute injuries, surgeries, pelvic surgery especially, back surgery, accidents, discompression, slip discs, strokes, chronic illness, diabetes, any of the neurologic disorders, not demyelinating disorders, can cause this. And a large percentage of patients with neurogenic bladder, we don't really know why they have it. They haven't had a stroke, their discs look okay, they don't have a degenerative nerve disorder, they don't have diabetes, they just have evolved this with time. One unidentified reason might just be childbirth. Having kids, just pushing a baby out through that vaginal canal is enough to traumatize the nerves between the bladder and the uterus and lead to chronic overactive bladders. Stress incontinence and urge incontinence are two different animals. Urge incontinence is fundamentally a bladder problem. Stress incontinence is fundamentally a sphincter problem. Okay? Let's talk about it just a little bit here. In stress incontinence, the bladder is relaxing just fine. It's filling just fine. It's not squeezing inappropriately at any point. But the sphincter mechanism that keeps the urine in the bag is not working. So when you cough, you sneeze, you squirt. That's stress incontinence. The pressure on the bladder is not coming from the bladder, it's coming from outside the bladder. It's a cough, it's a laugh, it's a sneeze, it's a jump on the trampoline. It's a whatever activity you like to do, but when you do it, that abdominal pressure overwhelms your muscle down here and you leak, okay? Urge incontinence is the opposite. It has nothing to do with what's going on out here. Your sphincter is just fine. In fact, your sphincter can handle a cough no problem. The problem is this bladder muscle starts squeezing when it shouldn't. And guess which is stronger between this muscle and this little tiny muscle? This muscle is much stronger. And it can maintain a sustained contraction over time because it's a different kind of muscle. This muscle is only designed to maintain a really high pressure for a couple of seconds. If you think about it, if you just stood here and squeezed your sphincter muscle really tight, called a Kegel, you know you can't hold that very long. right? Ladies who've all done Kegels, men who've had prostatectomies have learned how to do Kegels. You can't hold that for more than 3 seconds or you can feel it weakening because that's how it's designed. So if this decides to go on a nice, strong, sustained squeeze, this muscle will lose it after about 3 to 5 seconds. That's urge incontinence. So I know a bunch of you are now thinking, oh, I have stress incontinence, or I have urge incontinence, or I think I have both. And that is common too. Having both is unfortunately common. Overflow incontinence we're not going to really talk about today, but this is basically, remember we mentioned this hypotonic bladder business? That's where this comes into play. The bladder just won't squeeze. So it's chronically full all the time. You're walking around with a liter all day long, and there's just nowhere for it to go. So it just leaks out because your bladder's so full and tense, the urine just leaks out. We call that overflow. Okay, so let's talk about what we're going to do about this problem. This urgency, urge incontinence, overactive bladder, or mixed urge incontinence problem. And we call this a clinical care pathway. And this is kind of how a guy like me is going to think about taking care of this problem when you come in. So we talk about your symptoms. And there are lifestyle modifications you can make. And for patients who are motivated and try this, about half of them will see an improvement. Not a cure, almost never a cure, an improvement. The question is, will the improvement be enough that makes you happy? If you're seeing me, the answer is probably no. Okay. By the time you get to me, you've probably already tried this. But things like, oh, okay, I got to cut out the 2 cups of coffee in the morning. I got to cut out as much alcohol as maybe I consume at night, or I've got to watch when I have my fluids. I'm not going to drink a liter right before I go shopping, and I'm not going to drink before I go to bed, and that sort of thing. Maybe you lose a little weight. Maybe you realize, oh, as long as I stay on the Metamucil and I have my bowels are regular, I have less problem. So this does matter. And certainly anyone who has overactive bladder should do what they can in this regard. Behavioral treatment takes this up a notch. So bladder training, urge suppression techniques, pelvic floor training, this is really Kegel exercises. And if people can't really figure out how to do it right, we might put biofeedback with it to help them figure out what they're trying to do. Bladder training looks like, oh, I'm going to pee every 3 hours or every 2 hours, no matter whether I have to or not. But I'm not going to pee at any other time. So just because I'm going to the store, if it's not my time, I'm not going to do it. Because guess what? If you coddle your bladder like that, you just kind of perpetuate it. It's like raising kids or dogs, right? So you go every 2 hours, no matter what. Whether you have to go or not, you go in and go. And then after a couple of, or lots of weeks, you make that a little longer, and then you make that a little longer. When you get sudden urges, urge suppression techniques, you figure out what works for you, but you stop, you deep breathe, you think. And so a lot of patients can see improvement by employing pelvic floor training, urge suppression techniques when they do get an urge, and then slow and steady bladder training. This takes a lot of time. What's the success rate for a very motivated patient? And you got to be on this. It's like training your dog. I'm really serious. If you let your dog get away with it once or twice, you know you've lost months, right? It's the same thing here. You're like training your brain. Really motivated patients, studies have shown 50 to 80% will see a statistically significant improvement. Again, is it enough of an improvement? Well, that's where the research kind of argues. You know, what's enough improvement for the doctor and what's enough improvement for the patient isn't always the same thing, right? So, but that's certainly reasonable to do. What we're going to talk about from here on out are drug therapy and these therapies. Because this is where I can really help you. This is where the work isn't at home. This is where the work is up to us. So the anticholinergics have been around the longest. These are things like oxybutynin, trospium, tolterodine. You may have been on them. They've been around for a long time. They act on the M1 muscarinic receptor. When this receptor is activated, the bladder muscle squeezes. So by inhibiting it, you're making it hard for the bladder muscle to generate that unwanted contraction. One of the side effects of this that we struggle with, however, is it weakens the bladder's ability to squeeze. So yes, maybe you don't have as much urgency, or you have a little bit more time to get to the bathroom because it's not going quite as hard. It also doesn't empty as well. So sometimes patients who are already struggling to empty retain even more urine. Other side effects are dry mouth and constipation, and that's because you find M1 receptors in a lot of other tissue besides just the bladder. The newer ones out there, the beta-3 adrenergic agonists, they're the newer drugs. There's only 2 of them on the market right now, Gemtesa and Myrbetriq. They activate the other receptor in this muscle. When this receptor is activated, it actually relaxes it, okay? So this is an inhibition. This is promoting relaxation. You're encouraging the bladder to relax. This does not inhibit emptying like the other one does. Because once the threshold, the new threshold is overcome, this muscle works just fine, okay? So all this does is raise the threshold at which the bladder will then squeeze. But when it does squeeze, it's not inhibited at all. So that's why we all like it. Also, the beta-3 receptor is only found in the bladder and in fat. It's not found in any other organ, so it has very few side effects. There are some, it can raise blood pressure in some people. Some have reported headache, but it doesn't have any of these, and those effects are much less common. The downside to medications is overall long-term success is only less than 50%. I mean, less than 50% of people who come into my office will actually be on the medication a year later. It may have worked initially, but ultimately starts to fail for them, or the side effects are prohibitive and they just can't take it because guess what? I can't live constipated my whole life. Or it just straight up isn't effective for their problem. So in a lot of patients, the downside to this and what we have seen in research, patient research over time is they're given the medications by their family doctor, it eventually fails and they say, oh well, I guess that's what it means when you grow old. I just have to wet my pants. And they never get to us or our office, because in our office we won't accept this, right? That's not good enough for us. But a lot of patients end up not getting the referral, or they don't live by a urologist, or for whatever reason they just never get to the next step. Advanced therapies for neurogenic bladder are important because medications are going to fail over half of the patients. And they are mainly chemodenervation, also known as bladder Botox. Beautiful bladder, so beautiful. PTNS, which we actually don't use a ton, and then probably our most commonly used sacral neuromodulation. Chemodenervation is the idea that if I inject this muscle with Botox, it will do the same thing it does to muscle everywhere else in the body, which is paralyze muscle. That's what Botox does. It's a toxin. It's temporary. The body absorbs it or will metabolize it. But while it's active, it's paralyzing the muscle it's involved in. That's why if you shoot it in the little wrinkles here, if you shoot it in these muscles, those wrinkles will go away because those muscles relax and are not contracting. And that's also why if you have too much Botox, it looks like your face doesn't do anything, because it doesn't, because it's paralyzed. This makes it look like we're injecting the whole bladder. We really don't. I rarely go beyond this patch on the back wall of the bladder. We only inject the back patch right down to this area called the trigone. We have found that if we paralyze that, it will relax the bladder enough that the rest of the bladder muscle can still squeeze effectively to empty, but it drastically reduces the urge and the urge incontinence. So people can live their lives, fill up, have control, get to the bathroom on time, and not leak. The nice thing about it is we can do it in the office. Simple office procedure. Success rates are about 60 to 90%. It does wear off in time, so patients have to have it redone. So about every 4, 6, 9 months, depending on how well your body responds, you get to come back into my office, say hello, and get up on the table and have another procedure. But at least you're not having to go to sleep for it. We do it in the office, and it's really quite quick. It's not good in patients who have obstruction or whose bladders already don't empty well. So if you have mixed neurogenic bladder or hypotonic bladder, it's just going to make things worse. So one of the risks is if the wrong patient gets it or if it's overly effective, you may wind up with a catheter until it wears off. This is a little bit more what it really looks like. We use a flexible camera, not a rigid camera. And that's more appropriate size of the needle to your bladder. That makes it look like we're using a shish kebab stick. And it's just not that big. So let's talk about sacral neuromodulation. Botox is great, and it's particularly good for people who really cannot go to sleep, can't even have sedation in the operating room, really need to do something in the office. But if you're a patient who doesn't empty the bladder well, your bladder just doesn't work, you have mixed neurogenic bladder, you're not strictly overactive bladder, sacral neuromodulation is going to be a better option. It addresses the fundamental problem of neurogenic bladder, and that is the communication of nerve and bladder. So the reason this is probably the Cadillac of treatments for overactive bladder is it goes to the problem of communication. Injecting this using drugs, you're really hitting the end organ. With sacral neuromodulation, you're affecting where the problem originates, and that's in communication. Because of that, it works for both overactive bladder and hypotonic bladder. So by appropriately stimulating the nerves, you can not only shut down a bladder that's too excited, but you can also get a bladder to start working that isn't working appropriately. Because these nerves not only control the bladder, they also control the bowel behind it, it's really effective for fecal incontinence. So people who are pooping their pants and don't want to be, this can be incredibly effective. In fact, percentage-wise, even though it was developed for overactive bladder, it's actually more successful in stopping fecal incontinence than it is overactive bladder. So this is what it kind of looks like up close, and this is a little bit of a complicated picture, but this right here is your sacral bone. Up here are your lumbar vertebra. And you can see these nerves right here coming through these openings in the sacral bone, joining with a bigger nerve. This one's going down the leg. But these nerve roots serve various parts of our internal pelvic anatomy. The third nerve, particularly, is very strongly associated with bladder function and bowel function. So if I put a little stimulator, this is this black thing right here, if I put that little stimulator through that opening and just lay it right next to that nerve and connect it to a battery up here, I can solve the problem of overactive bladder. Significantly improve overactive bladder and how the spinal cord communicates with the bladder and the bowel. This is implanted kind of right up here in the tissue right there. So it's all implanted. So I like to call it a bladder pacemaker. That's not entirely accurate. Medtronic would probably disagree with me. They're the ones that make both of them. But it kind of works like that. It's like a bladder pacemaker. It's done in 2 stages. The first stage is a test. So the first stage, no incisions, just 2 little needles, and I put 1 temporary lead on either side. And for a week, we just test it. You have a little light sedation in the operating room. It takes me about 15 to 20 minutes. Get that all set in, all bandaged up, and for 1 week, you get to try it. If it works, hallelujah, we can put the real McCoy in. If it doesn't work, no big deal. Those 2 leads are pulled out right in the clinic. So the trial lasts till 1 week. The second stage is the full implant where you get the battery, you get the lead, the whole thing, and it's all implanted. That usually takes about 30 to 40 minutes. Same day procedure both times. If someone can't actually have full anesthesia, we have done many of these on simple sedation. This is the newest device up. So this device is controlled by a smartphone-like device. It's actually made by Samsung. And this is the little communicator that does the Bluetooth talking to this device and this device. That's the permanent one. This will last you about 10 years without being changed. This one is rechargeable and will go 15 years. I think it'll actually go 20. They tell me 15, but like at 15 years, it's still got like 90+% of its battery in it. So it probably goes longer than that, but the company won't approve of me saying that. So once implanted, this has got 7 different programs. They can go up and down in strength. There's extra customization things we can do, including pulsed stimulation and whatnot. So very customizable. It's MRI compatible, so if you have to have MRIs, that's not a problem. And incredible support from Medtronic. And we recently had an InterStim Center of Excellence award for them. We're grateful to that for helping us out. I don't think we would have got there without their support, but that's very good. We're happy to be able to offer that.